We're going to talk about suspected appendicitis this morning. This is on page 159 in your manual. This talk is called Imaging and Suspected Appendicitis, but we're not going to just talk about imaging. We're going to talk a little bit about some of the other recent literature that's come out, mostly in the surgical literature, about some other ways to look at appendicitis, challenge some of the dogma we might believe about appendicitis. But I think the focus of this chapter is really that we've come with the diagnosis of appendicitis from somewhere where it was really a clinical diagnosis to somewhere where we're ordering a lot of CT scans. And for some people, that doesn't seem like such a good thing. We all have feelings about how many CTs we're ordering and whether it's helpful or not. But the fact of the matter is we're in an era of a lot of imaging, and we're going to look at some of the literature about whether or not this is an evidence-based thing that we're engaging in. Are we really doing our patients benefit? Is there a clinical benefit to all the imaging that we're doing in our suspected API patients? The first question that the chapter poses here is there a clinical decision rule that can identify pediatric patients at low risk for appendicitis? Certainly we all know what the surgeon's clinical decision rule is, which is, what's the white count, what's the CT show, right? Very simple decision rule. But for us, it's a little more complicated, and we would all love to have a system that we could use to decrease the amount of scans. I think that's really the ultimate outcome, is could we find a way to not order as many CT scans as we seem to be ordering these days? And number one is a paper from Children's Hospital of Boston, which tried to develop and validate a clinical decision rule to identify children at low risk for appendicitis, with the goal, again, of trying to reduce the number of CT scans that we're ordering. They performed a derivation set of about 425 kids and validated it in 176 children. And they developed a point scale where they assigned points for different clinical features. You got a point if you had difficulty walking. You got a point if you had a history of pain going down to your right lower quadrant. You got a point, or 2 points, for rebound pain or pain with percussion. 2 points for nausea, 2 points for focal right lower quadrant pain, and you got 6 points for an absolute neutrophil count, not a white count, but absolute neutrophil count of greater than 6,750. If you had less than or equal to 5 points on this scale, you were considered to be at low risk. That's probably not a child that needs to have a CT scan or a surgical evaluation emergently. That could be someone that would be safely able to be discharged home with a follow-up and a recheck. Interesting, 5 points was their cutoff, but you got a full 6 points if you just had the white count alone. And in this group that they looked at with these points, it was pretty sensitive. They had a 98% sensitivity rate, but using these rules, they still would have missed 4 cases of appendicitis, and they would have decreased their CT utilization probably 1 out of 5 times, 20% they estimated. So you could look at that in a couple different ways. Yeah, that was some benefit there, 1 out of 5 times, but then again, that's only 4 out of 5 times you're still doing it. And it depends on what your acceptable miss rate is. There's 4 cases acceptable to you to have missed. How did those children do? We don't know if the delay would have really meant something, but that's one way to look at it. One thing that I took away from this with all these different criteria was that this is a complicated decision to make, and there are a lot of different features that go along with this, and there's no perfect way to tell who has appendicitis and who doesn't, which is what leads us into all this imaging that we seem to be doing. Interestingly, this actually just in February last month in Academic Emergency Medicine, these same authors published again, and they're continuing to look at their set of patients. They're up to like 700 patients now, and the title of their paper that they just published in February was Atypical Features of Appendicitis in Pediatric Patients. And the point of their new paper was just that it's very atypical. The pediatric population has a lot of atypical features, and in fact, in their new look at their set of patients, there were 44% of the patients they said really had just atypical features, and you couldn't have made a rule about them. So it's a difficult decision to make, and I don't think there's any simple decision rule that you can use to rule in or rule out appendicitis, but this is one look at it. Papers number 2 through 8 look at the use of ultrasound in appendicitis. How many of you are frequently ordering ultrasound to evaluate your rule out appendicitis patients? Anybody? Not many, 1. Not that common. And I think the reason is probably that at a lot of the places that we work, we know that ultrasound is very operator dependent. And if you don't have a technician, certainly available 24 hours, that's one thing, but a technician that you can count on to make this diagnosis on a pretty regular basis, or that your radiologists are feeling comfortable with this modality, it may not be something that you use frequently where you work. Papers 2 through 8 look at ultrasound. 6 of these 7 papers are all international papers coming from outside of the United States. And certainly these kind of papers are written by people who can do ultrasound very, very well. So there's some question of external validity with this kind of literature, whether or not it applies to your institution where you work, if this is something that you can count on. Certainly the people who can use ultrasound well feel that this is almost as good as CT scan in the right hands. If you have the right kind of ultrasonographer and radiologist who are very comfortable with this imaging modality, it can be a very, very useful tool. Ultrasound and appendicitis is what they call graded compression, where they look for a tubular structure in the right lower quadrant. They try to compress it. If it's inflamed, it won't compress down, and that's how the diagnosis is made. Ultrasound has some pluses and some minuses. It's actually really good in people who are thin and you can see very well, and it performs well in those kind of patients. So in obese patients, ultrasound doesn't perform quite as well. Certainly it doesn't give you the advantage of alternative diagnoses like a CAT scan does. You don't get to see what else might be causing their right lower quadrant pain for the most part. And if you have a retrocecal appendicitis, not as good at looking back beyond what's kind of in the front. And if you want to rule in or rule out perforation or an abscess, it may not give you as great a picture as a CAT scan does. So there's some limitations to the modality, but certainly there's the advantage that you don't have radiation, and that's a big plus when you're talking about looking at pediatric patients or pregnant patients. So there's some real pluses there where you would really like to use it more. It's faster, you don't have to give people oral contrast, so a lot of pluses there. The next question is about whether or not you need to use oral contrast in in your imaging of your suspected appendicitis. And papers number 9 through 12 ask this question. Certainly we know that oral contrast slows things down for us. It takes a while to get it in, we have to wait, it's, really prolongs the whole diagnosis. And the fact of the matter is that these papers say, the evidence says that you don't need to use oral contrast to get a good CT scan image to diagnose appendicitis. Now certainly again, this is written by radiologists who feel comfortable reading these scans, and you may not work in a place where your radiologists want to do non-contrast CTs for appendicitis. Maybe they weren't trained that way, that's not what they want to do, but I want you to know that this is what the evidence says, that you don't have to use oral contrast to make the diagnosis of appendicitis. That's what these papers are saying. Now I'm going to look at a few of these with you. Number 11 is a prospective comparison of helical CT with and without contrast, where they scanned people with oral contrast and then they did it again without, and they compared what these two different scans looked like. They had different radiologists interpreting the before and after CT scans, and they found a lot of disagreement about what they saw on with and without oral contrast scans. Most of the disagreement was just between the radiologists disagreeing about what the scan said, but it didn't really have anything to do with the oral contrast. It was really just more interpretation of other aspects of the scan when they looked back at what the differences were. But what it does say is that there's a lot of inter-rater agreement issues with CT scans and radiologists in general, which we've seen in a lot of papers. A lot of inter-observer variability. But again, that wasn't the oral contrast that made a lot of that variability happen. It was more just the radiologist reading the scan. Number 12 was a systematic review of 23 different studies of over 3,000 patients with different modes of contrast. Rectal contrast only, oral contrast only, rectal and oral together, oral and IV contrast, looking at all different kinds of studies and tried to come up with a conclusion about what does the literature say about these different types of contrast. And what it does say is that non-contrast CT is just as good as the other protocols in the studies that are out there. If you want to talk about the second best, about non-contrast CT, what comes right after that, which is really rectal contrast being equivalent to oral contrast. But the fact of the matter is, your patients, if you gave them a choice of would you rather have oral contrast or rectal, I think most of them would probably pick the oral, and certainly your radiologists that have to put the oral or the rectal in would rather you do the oral as well, which is another reason that we're kind of left with that technology. But I think that as CT scans and the technology advance, it's going to be harder and harder for people to make the argument that you need contrast at all as the imaging gets better and the pictures get better. And I think that a lot of us who have night hawk at night or send off our reads at night, if you do some non-contrast CTs, let's say you might have thought it was a kidney stone, you can get back those readings that do give you details. So I think we all believe that that's true, that you can do a non-contrast CT and see some real changes there. You can make alternative diagnoses, but the radiologists, a lot of them put a pressure on us to keep the contrast going. So it depends on where you work. This is not a decision that you can make alone, but the evidence says you don't need the oral contrast. So what's the evidence that supports the use of CT at all? Certainly we're not going to get away from using CT scans, but what's the evidence that says that it's made a big difference in our patients? And number 13 through 18 are all the pro-CT papers that tout a lot of advances with CT scanning in general. And I think that the question about CT scanning is about selective CT scanning. Who can we select to CT scan? Those are the patients that really benefit the most. And certainly in males versus females, we have some real differences. And females have a lot more in terms of differential diagnosis that CT scan can help us with. Most of the papers talk about, they compare whether the negative appendectomy rate before and after implementation of CT guidelines or implementation of CT in general, looking at time periods. And we're going to talk about a few of these. Number 13, it's not a great study, but it has some interesting numbers. This is a paper from the University of Texas, Galveston, which is a chart review of patients who had appendectomy before or after implementation of a guideline in their department that employed more CT scanning on a selective basis, but more CT scanning in general. And they looked at the rate of negative appendectomy before this guideline was implemented and then after. And the most impressive group that it really made a difference was the women. They went from a rate of negative appendectomy of 47% before the implementation of CT scans to 6% after the CT scan. So in that group of patients, it really did make a difference on their negative appendectomy rate. Number 17 is a pretty recent paper from the Resurrection Medical Center in Chicago that also retrospectively looked at the negative appendectomy rates in 122 patients and looked at whether or not they had CT scans before their surgery. And 87% of the patients in the study did have a preoperative CT scan, and their negative appendectomy rate overall was 6.6%. In the patients who had a CT scan before their surgery, only 3.8% of those had a negative appendectomy rate. But the ones that didn't have CT scanning, they said it was 25% negative appendectomy rate. But actually, because of the low numbers, it was really only 4 out of 16 patients who didn't have a CT scan before, and 4 of them had a negative surgery, so they said it was 25%. This is just an illustration of how these numbers can be kind of twisted around depending on how many patients you have in your study. Number 18 is a prospective study from the Carolinas Medical Center that looked at the impact of non-contrast helical CT in 101 patients who were being evaluated for appendicitis. And these patients were all evaluated by the emergency physician and by a surgeon. And they had the emergency physician and the surgeon write down what their dispo was going to be before they did the CT scan. What do you think this person has, and what are you going to do with them? Just take your best guess before we do the CT scan, and then we'll look and see what happens. And it turned out that the CT scan changed the disposition for the emergency physicians 35% of the time, and for the surgeons 27% of the time. So about a third of the time it made a difference. And the rest of the time it didn't seem to matter. The disposition was the same. There were a couple cases who proved to be appendicitis, but that the emergency physician and the surgeon were going to send home. So two people out of 100 really had a big change in what their management was going to be. Okay. Number 19 this comes after the question, even when we're certain clinically that it's appendicitis, should we do a CT scan? And really, actually, there's one paper listed here, which is number 19, which actually doesn't use CT scan at all. It used ultrasound. But I guess the question is still valid, which is when you examine somebody and you're sure that it's an appendicitis, should you still image them at all? And I think that this is a question that you have, certainly, but also a question that some surgeons look at different ways. I'm sure a lot of you do work with some surgeons who don't want CT scans all the time. It's certainly a surgery preference thing. For me, a lot of the younger surgeons that are training in my institution at USC now, they want CT scans on everybody, and that's how they're being taught. And, but we know that there are certainly older surgeons who learned how to operate before CT scan, and if you're sure about it and they're sure about it, they don't want to image everybody. So we're kind of all over the map on this. But this paper, number 19, was an Austrian study that looked at 350 patients, ages 5 to 92, all over the board, with suspected appendicitis. And they had 4 experienced surgeons lay hands on the patient and give a chances, whether, is this a low risk, a high risk? How would you rate the chances of this person having appendicitis? And then they imaged them all with ultrasound in this case, and they correlated what the final result was with what the surgeons thought the risk was going to be. About just under half ended up having surgery, and the rest of them they clinically followed up to make sure that they didn't have appendicitis if they didn't go to surgery. And of the surgeons, of the patients that they thought were high risk, 65% of them turned out to have appendicitis on the imaging. And so it's not perfect. Certainly our clinical impression, even in an experienced surgeon's hand, is not perfect. I think that the point here is that if you have a very high suspicion and you have a very high sensitivity or a very good test at making this diagnosis, these can be beneficial together. But certainly, I don't think the message is that, if you have a patient that you think really does have appendicitis, not all of those need imaging. That's certainly not the case. Some surgeons, again, would agree with you, and they don't want imaging on everybody, and we don't want that either. So certainly we wouldn't image everybody. How about the CT isn't as great as everybody thinks papers, which you may be in that camp. And if you're in that camp, then number 20 through 24 are for you. These are papers that say CT is not Nirvana. We haven't made a big difference with all the CT scans that we're doing. One paper that's not actually in this series, but was a big paper, was a paper that was published in 2001 in JAMA by a guy named Flum, F-L-U-M. And it was a very large study, got a little bit of press at the time. It was a big population-based study in Washington State where they looked from 1987 all the way through 1998 and looked at 65,000 people who underwent appendectomy in that state and sort of compared in the pre-CT era in the 80s and early 90s where we weren't doing quite as many CAT scans as we do now to the later 90s, and really what was the negative appendectomy rate and how was the overall health of the patients in their population, and found that there really was no difference, that this imaging didn't make a big difference. And it got a little bit of press at the time. This is a really big population-based paper that argued against the overuse of CAT scan, that it's not doing a lot for our patients. The papers that we have here, number 20 and 21, are retrospective studies, not so great. Number 23 is a pediatric paper from Columbus, Ohio, that did a retrospective review of charts of 720 kids who got appendectomies. And they looked at the association between the CT results and the outcomes, perf rates and negative appendectomy rates, that kind of thing. And they found that interesting is just how much CT usage we've done. In 1998, they had 18% of their children were getting CT scans, and by 2001, that had gone all the way up to 51% of the children in their study were having preoperative CT scans. The ultrasound rate, interestingly, had gone from 20% in 1998 only to 7% in 2001, so it actually had gone down in that same period of time. The perforation rate from that period of time went from 42% to 31%. So a little bit lower, but it was not statistically significant, actually. And their negative appendectomy rate in 1998 was 10% versus 6% in 2001. Again, it was not statistically significant. So the conclusion was that this wasn't a statistically significant difference. Yes, it was a little bit lower, but in this group of children, not important enough to say that it was a big difference. Number 24 is from UCSD and also looked at the implementation of a guideline encouraging selective CT scan in a department and looking at the negative appendectomy rate before and after the use of CT, the increased use of CT. And they also found that their negative appendectomy rate did not significantly decrease by increasing the use of CAT scan in their department. Next question is, does age and gender affect the CT yield? And we've talked a little bit about this already. Probably in women, it certainly does affect the yield of your CT scans. Number 25 and 26 asked this question. Number 25 is also a very big population-based study from UCLA that retrospectively looked at over 75,000 patients in California who underwent appendectomy between 1999 and 2000. And they looked also at the relationship between preoperative CT and the negative appendectomy rate. The overall rate of negative appendectomy was 9%. And actually, CT, again, did not have a big effect on the overall negative rate of appendectomy, but it did have a big effect in one gender group, again, women. The negative appendectomy rate went down from 13% pre-CT scan to 10% afterwards. And this was especially true at the extremes of age, at kids and older adults, certainly, again, where the differential diagnosis is a little bit bigger, clinical exam not as reliable. And in this big population, this actually was a statistically significant difference. So in females, again, helpful, and at extremes of age, helpful as well. What about pregnant females with a suspected appendicitis that you don't want to radiate with CT? We've talked about ultrasound might help. But the next two papers, number 27 and 28, also say that MRI performs pretty well. So if you work somewhere where you have access to MRI, this may be also an alternative imaging modality that in these little small studies looking at imaging these pregnant females was pretty good. It takes a long time. There's some downsides. The whole thing, it's expensive, not accessible 24 hours. But just so you know, MRI performs pretty well and has the added advantage of giving you some alternative diagnoses besides just what you're looking at, the appendicitis. Number 29 is an interesting little paper. Where is the appendix located in pregnancy? And I think we all learn in medical school and anatomy that as the gravid uterus starts to grow, the appendix gets pushed away. It gets pushed up out of the right lower quadrant where you expect it to be. And number 29, this little Iranian study looked actually at women who were undergoing surgery for different reasons and where was their appendix. They visualized it with the retina and recorded where the location was. They looked at 165 women who were undergoing C-section. These were women who were at 37 to 40 weeks of pregnancy. And 26 females who were undergoing surgery for suspected appendicitis at the intermediate point, 19 to 39 weeks of pregnancy, and then 100 non-pregnant controls. And in their surgery, if the appendix was 2 centimeters within where McBurney's point is expected to be, they recorded it as normal. It's in the right place. And actually, the percentage of time where it's in the right place or where you'd expect it to be is probably higher than you think it is. And in fact, the point of, after looking at these cases, they determined that, you know what, the pain should still be in the right lower quadrant. Sometimes it might shift around a little bit, but in general, it should be around the right lower quadrant, much more than you think it will be. It should still be right down there. Now, number 30 to 33 are papers that ask this question. Do we need to operate on appendixes in the middle of the night? Is it really as emergent as we all think it is with the advent of antibiotics or more efficacious antibiotics? Now, let me ask you, who do you think wrote these papers? The surgeons. And what do they want to avoid? Coming in the middle of the night. They want to prove that these people don't get worse after 12 hours waiting for surgery. And it's an interesting question. So number 30 through 33 are these surgical papers who look at people who basically had delayed surgeries for different reasons and tried to prove that, in fact, their outcomes aren't that bad. And so maybe we don't need to operate on these people in the middle of the night. And these are all chart reviews, so they're not prospective type studies where they randomize people to have delayed surgery or not. They're where they look back at people who ended up having delayed surgery and what were their outcomes. Certainly, I think if you think about that a little bit, certainly people who have delayed surgeries were probably not as sick to begin with. So you're going to probably, just even thinking about the logic of it, you're going to have better outcomes in those folks anyway. But certainly their conclusions are, as you can guess, that most of the time they do okay. They have slightly increased length of stay. They may have the occasional perf or not, but in general, that you're not doing your patients a big disservice by delaying the surgical patients again. Number 30 is a paper that looked at patients who had surgery within 12 hours versus group who had surgery at 12 to 24 hours. All of them got fluids and IV antibiotics, and they try to make the point that these patients did okay. Interestingly, in this original manuscript of this paper, number 30, there is some discussion that follows, and this paper was presented at the New England Surgical Society, and so they record then what the surgeons comment on in their, after their abstract presentation. And there was one surgeon comment afterwards that says, you know what, you guys should be ashamed of yourselves that you're even publishing this. The fact of the matter is that this teaching institution that you're talking about, you had 78 patients who had to wait, more than 12 hours for a surgery. These patients were in pain, and it's an abomination. So there's certainly a lot of controversy even within the surgical world about this kind of a paper that suggests that delay is even a possibility. But it's a question that they ask, and the fact of the matter is the evidence here, again, limited scientifically, but that patients don't do terrible if you delay their surgery. Number 33 also looks at temporizing patients with IV antibiotics and delaying to do your surgeries during the day. And in fact, again, patients had slightly longer mean lengths of stay. It went from 1.8 to 2.3 days. That was the overall delay, overall length of stay delay with the delayed surgery. But the conclusion was that it was safe to delay. So just so that you're aware that this literature is out there for your surgical colleagues, if they suggest delaying for whatever X reason, that there is some evidence to support that it's not as dangerous as we all think it is. But again, realize what the kind of intuitive things are that argue against this kind of literature. I know it makes us really mad to hear about this. I hate this little section, but just to let you know that it's out there. The last study, number 34, asks an interesting question, which is, do we really need to operate at all? And this is a Swedish paper, and it's just one paper, but I'll tell you that there is one paper that came out even more recently than this one. What they ask is, couldn't you cool off a lot of these appendicitis cases with antibiotics? Isn't it just a kind of diverticulitis, in fact? And now, with diverticulitis, we're sending a lot of these home with antibiotics, and maybe appendicitis is something like that too, that we could just cool off. So it's a Swedish study, number 34, that looked at 252 men aged 18 to 50, and in Sweden, they really like C-reactive proteins. So a lot of their diagnosis of appendicitis was based on very high C-reactive proteins in the right clinical setting. So a little different than how we practice. But they basically randomized these groups to getting admitted to the floor for antibiotics or going to the OR. And they compared how the two different groups did. If you went to the floor and got antibiotics, you were watched, and if you got worse, you went to the operating room. But I was just curious to wonder what kind of antibiotics they gave. They gave cefotaxime and an equivalent of Flagyl. And if they didn't get better in 24 hours, they operated. But if they got better, they went home with oral antibiotics. They gave them ofloxacin and, again, a Flagyl equivalent. 12% of those who were admitted to the floor for the IV antibiotics needed to have an operation, 12% that actually ended up going to the OR. And of those, just by the way, those 15 people, 7 of them did have a perforation, so a pretty significant number. Of the people who went home, they all did pretty well. 15% of them had a recurrence of their appendicitis, and at about an average of 4 months, they came back with the same symptoms and ended up having to have surgery, but that means 85% actually did well. And I think that this kind of paper is not going to change the practice, certainly, in our country about how we look at appendicitis. But what it does, how it is a little bit applicable is to patients who are not very good surgical candidates that would really face a risk of undergoing surgery for their appendicitis. This is the kind of paper that justifies maybe cooling them off with antibiotics, or at least giving it a try, that there's a chance that some of those patients are going to do okay with antibiotics alone. I can tell you that in my institution how the surgeons are using this paper and a subsequent paper that looked very similar to this is patients that are morbidly obese that they judge as not very good surgical candidates, that these are people that they admit to the ward and try to cool off with antibiotics and save them from an open appendectomy that's not going to heal well and they're going to have a lot of complications from. If you have an alternative out of that, maybe it's something that you should consider. And that's why I just put 34 out there to challenge the dogma that all appendicitis has to go to the OR. Maybe there's some exceptions there, certainly not for everybody and not for healthy people, but there might be the occasional person that might get cooled off with antibiotics.